He's a senior pediatrician and he's worked as in a IIP working chapter. So in 2021, he was with us in a journal journey this month only, and again he has given his time to IIP Raigad. We are very, very thankful for that. I request all the delegates to kindly mute yourself to avoid unnecessary disturbance. Now I request our dear Pramod sir to give the presidential address, and also he will be moderating the session. Over to you, Wankhede sir.
Thank you, Vikas. And good evening, friends. Our respected guest speaker, Dr. Abhay Shah sir, our Maharashtra IIP President, Dr. Hemant Bambulia sir, Vice President, Dr. Vinayak Patil sir, past Vice President, Dr. Dabadkar sir, our godfather of Raigad IIP, and many dignitaries. Actually, I am not seeing, but dignitaries on the board, of the board. Mohite sir आहेत का? Mohite sir, President National Critical Care. Friends, as a IIP Raigad President, with my commitment, this is our 6th subspecialty chapter lecture. Particularly this month, since we are at the verge of welcoming monsoon, we are also expecting a monsoon-prone diseases also. So we should be prepared to tackle these diseases, how to approach, how to treat, how to investigate, and just to replenish our brain, just to update our update our information regarding the diseases. Today we have a very big person, a person of very high caliber, Dr. Abhay Shah. He will enlighten us with his vast experience and knowledge. Actually, Dr. Abhay Shah sir needs no introduction. Dr. Abhay Shah, bas naam hi kafi hai. Sir, but as a protocol, we have to introduce him. Dr. Abhay Shah sir is a very excellent academic career. Since MBBS, MD, and diploma in pediatrics, all he was gold medalist, and with flying colors in fellow IIP also. Sir is the director, Children Hospital, Pediatric Infectious Disease Center, Maninagar, Ahmedabad. Sir was an active member of ACVIP in 2020-21 and 18-19 also. Sir was National Scientific Convener, IIP Action Plan 2021. Sir was Executive Board Member, Central IIP in 2018, in 2012 and 9 also. And he was the chairperson, ID chapters in 2015. Sir has recipient of many top class orations, that is Tapan Kumar Ghosh Memorial Oration in 21. He was the recipient of Dr. Sivananda Oration 2015, and he was the member state monitoring group, Lakshya Improvement Program, Government of Gujarat. And he was a resource person and contributor for more than 25 IIP modules. Many publications, more than 50 publications to his credit. And it's an honor that he's on editorial board on IIP textbook of pediatrics, textbook of pediatric infectious disease, IIP textbook of vaccine, IIP guidebook on immunization, color atlas of pediatric infectious disease, frequently asked question in pediatric infectious disease, immunization in clinical practice and second edition, the textbook of pediatric tropical diseases, frequently asked question in rational antibiotic therapy, handbook on infection control in hospital settings, and IIP question answers in vaccines and vaccinology. He has got authority in vaccinology. We are planning to have a lecture on vaccinology also, but I assure that would be a physical lecture. So with this brief introduction, actually sir has got endless introduction but in short, we have to cut it short. And I request Dr. Shah sir to take over the charge and to start.
Yeah, so
Very
I'm
much.
sharing the slides.
Yes, sir. Yes.
Yeah. I'm audible, visible?
Yes, sir.
Yeah.
Yes, sir.
So good evening, everybody. IAP, Raigad branch, Maha IAP, all the dignitaries on the dais, President of Raigad branch, Dr. Wankhede sir, Secretary Dr. Vikas, Dr. Dhananjay, Treasurer, Maha IAP President Dr. Gangulia, Dynamic Secretary Dr. Amol Pawar, and Bhisma Pitamaha of Rural IAP, my good friend, my co-EB, Dr. Shekhar Dabhagar sir. So it is indeed a great pleasure. Of course, there are so many stalwarts, but I am not naming everyone. So please excuse me to honor the time it. And as rightly mentioned in a preamble by our beloved President Dr. Pramod sir, that the topic is very catchy. That is monsoon maladies. I think we are in the mid of the June, and we are very all up the scorching heat. We are very eager to welcome the monsoon. So the monsoon brings lot of refreshment, lot of pleasant moments, but at the same time, this monsoon often becomes the epicenter for the various diseases. And in a country where the resources are very poor, where the drinking water is not that safe, where the sanitation and extra disposal is not that adequate, and when we are living in the slums or in the remote rural areas, probably these areas can become the hub for the various tropical diseases which are more prone to occur in monsoon. Why? Because the environment itself is going to be conducive for the various vector-borne diseases. There are a lot of houseflies, lot of mosquitoes, and a lot of ticks and mites, and probably they can give rise to diseases like malaria, dengue, chikungunya, Japanese encephalitis, Zika, re-emerging infection like Congo fever, scrub typhus, hand-foot mouth disease, whatnot. Similarly, it is also associated with the contamination of food and water, and therefore the diseases which are transmitted by the fecal-oral route are also there, like typhoid, hepatitis A, gastroenteritis, and if there's a lot of clogging is taking place, probably leptospira can also be there. And we should not forget air, and they causes influenza, flu-like illnesses, common cold, even pneumonias, and even COVID. So friends, we say that water and air comes to us without any charge. No, they cause diseases for the human beings, for the animals, as well as for the plants. So of course, water and air are free, but at the same time, they can be expensive as far as our health is concerned, probably when they are polluted, more so in the monsoon disease, monsoon illnesses. Now, a child who has come on day one in my OPD, in my emergency room, the first and important thing, irrespective of the cause of the illness, it may be malaria, dengue, whatever it is, the first and important thing is to triage the child. Whether I am looking at a febrile, well-looking child, or whether the febrile child is ill-looking. If the child is ill-looking, I think red flag signs are present. The child needs urgent hospitalization, intervention in terms of stabilization, and also investigation as well. If the child is well looking, probably a symptomatic treatment, proper hydration, nutrition, paracetamol, and wait and watch policy is important. And we'll explain the parents about the various red flag signs when the child should be brought to the health facility, which are the danger signs are there. The only exception to this is that if the child is febrile neonate, if the age is less than 3 months, if there is immunocompromised child, or if there's an outbreak situation, probably we need to be very careful. And these are the child, even if they are febrile, well-looking child, require early intervention. So I think this is a basic concept also the febrile illness of any child of during any season is concerned. So what is special about this monsoon illnesses? So first and important thing, it is a history and thorough physical examination. The history will include various epidemic factors, travel history, drug history, etc. And we need to assess and stabilize the airway, breathing and circulation. Unless you take care of the airways, breathing and circulation, no amount of any antimicrobial, no amount of any antibiotic is going to work. And therefore, you have to look for the signs of systemic inflammatory response or the upcoming shock. So any child who is tachycardic, who is tachypnea, or the blood pressure with a narrow pulse pressure there, I think it's a red flag sign, and that child needs to be urgently stabilized. Once the child is stabilized, you will give on the various details of the fever. That is what is the pattern of the fever, whether it's a high grade to start with, low grade to start with, how it is responding to paracetamol, how is the interfebrile period is there, similar family history is present or not. This will help us to find out whether we are dealing with a viral illness or a bacterial illness. Then evolution of rash, organomegaly, icterus, third spacing, and multi-organ enrollment. So all these factors are very, very important because it will help us to have a syndromic approach. So this examination will find out whether the focus of infection is present or not. Suppose the child has got the exudate tonsillitis, suppose child has a pneumonia. I think then in that case, appropriate antibiotic will be started upfront, or sometimes we may take the blood culture and then start the antibiotic. So if the focus is present, there is nothing much to worry about. If the focus is not there, then a thorough clinical examination, various risk factors, geographical factors, season, epidemiology, and associated symptoms are very, very important. And this conglomeration of the various associated symptoms in a febrile child is described as a syndromic approach. That means a child in a monsoon season may have a fever with rash, child may have a fever with jaundice, child may have a fever with respiratory distress, child may have a fever with encephalopathy, child may have the fever with multi-organ dysfunction. So this is the syndromic approach is very, very important. Now, what is the syndromic approach is there? So probably most of the monsoon fever will mainly start as an undifferentiated fever. It may be malaria, it can be scrub typhus, it can be typhoid, dengue, lepto, or any other non-specific viral illness, but there will be a undifferentiated fever. Second group is that, which is more common, is a fever with rash, with or without thrombocytopenia. And here the common group will be dengue, rickettsial infection, meningococcal infection, malaria, actually severe malaria, lepto, and other viral exanthemas. Similarly, the child will have a fever and CNS manifestation. Here we have got the acute encephalitis syndrome, and common cause is meningitis, herpes simplex encephalitis, Japanese encephalitis, scrub, dengue, H1N1, and we should not forget even typhoid encephalopathy and cerebral malaria itself. Sometimes the child will have fever, but predominantly a respiratory problem. Here you have to find out various flu-like illnesses, scrub typhus, falciparum, H1N1, lepto, and hantavirus. And last one, that fever with multi-organ failure, it can occur with malaria, dengue, scrub, and lepto. The first and important thing that you try the child, stabilize the child, looking at the seriousness. Then you apply a syndromic approach, and this syndromic approach will help us to narrow down the differential diagnosis, and accordingly, you can be very rational as far as our approach in terms of investigation and treatment is concerned. Now, I will take a few of the cases. A 4-year child comes in the monsoon, fever with rigors. There was no cough and cold. Headache was there, which is mainly periorbital. Body ache was there. Some typical rash, maculopapular, mollified measles-like was there, and number of cases in the surroundings. So from the history itself, we say that yes, this cannot be a bacterial because the child has got a fever, rash, cough, fever, rash, and periorbital body ache. Typical rash is there, so probably it is going to be a viral illness. Now, which are the condition which presents in like a fever with rash? The commonest one in the topic will be hand, foot, and mouth disease, dengue, chikungunya, rickettsia, or even some other causes like meningococcal. But looking at the seriousness of well-being child is there, probably meningitis is not the differential diagnosis in this case. So the child was having a typical exanthema as well as anathema. You can see that fiery red throat. You can see the petechial or the pelleti. You can see the ulcers, and similar vesicular lesions are there on the sole as well as on the hand. So the diagnosis is that there is a triad of fever, vesicular rash, and upper respiratory infection. So it's a case of hand, foot, and mouth disease. Most of the time, it requires only symptomatic treatment. Please do not prescribe the antibiotic here because the throat is so much congested and red. You have to be very rational. This is a situation, you have to be confident, and here the antibiotic is not required. However, if the child has some cardiac involvement, child has some neurological complication like this, then remember that it can be because of the enterovirus 71, and here some intervention is also required. So most of the time, in a hand, foot, and mouth disease, is a self-limiting benign illness, requires only symptomatic treatment, does not require any antibiotic, but complications are known to occur provided it is caused by the enterovirus 71. Now, another child is that a 5-year-old male child, again a monsoon season, high grade fever with chills for 3 days. There was headache, there was body ache, the nausea is there, temperatures were spiking 103. ENT examination was totally normal, spleen is just palpable, and rest of the systemic has been normal. So from the clinical examination, the fever with rigor, headache, body ache, and nausea, and spleen is just palpable. So it can be either malaria, or in the monsoon season, it can be either chikungunya or it can be a dengue. So these are 3 common situations. And as the child is having a fever of 3 days with chills, not taking orally well, we investigated, and there is some leukopenia was there, mild thrombocytopenia was there, malaria parasite was negative, rapid antigen test for malaria negative, SCBD was slightly raised, and NS1 dengue is negative. So first, an important question that comes in my mind, that when a child in monsoon comes to with a fever, what is the role of CBC? That is the most important that question we need to ask. So we should not ask CBC just as a knee-jerk response. We see that number of laboratories now giving a fever profile, and number of clinicians are giving that are ordering the fever profile without any thought process. So very, very important that CBC has more of a negative predictive value. Of course, if you pick up a malaria parasite, it will give you a specific diagnosis. Otherwise, it is going to give us the trend of the count, how the WBCs are performing, how the platelets are behaving. So it will provide us a trend of the disease, pattern of the count. So a single CBC has no value. It mainly carries a negative predictive value. And this is a very useful chart that we all know that is a WBC count with a polymorphic predominance is there, then probably it's an acute bacterial infection. If the WBC count is normal, poly is less, but lymphocyte is more, probably it can be a typhoid fever. If the lymphocyte count is very high, eosinophil count is also low, probably acute viral infection. If the WBC is so leukopenia is there, if the hemoglobin is increasing, if the platelets are falling, means hemoconcentration with thrombocytopenia, it can be a case of dengue.
Simple.
And as far as the malaria is concerned, usually the child will have the anemia. Out of this, eosinopenia is a marker for the enteric fever, and for the eosinophilia, I think most of the time it can be a malaria. But again, these are the non-specific. They have more large number of variables, and you should the presence of eosinopenia will not confirm the enteric fever. Absence of eosinopenia does not rule out the typhoid fever. So it is very important that you look at the count in the right perspective. So the CBC has a more negative predictive value rather than positive predictive value. It is non-specific. Serial CBC may help. It may give a possible trend of the illness. However, sometimes specific diagnosis like malaria or leukemia due to presence of abnormal cell or presence of malaria parasite can give a specific diagnosis. So do not just order the CBC just because the child is fever. Look at the child, whether the child whether the child is sick or not, whether you can wait for or not. Otherwise, it will misguide you rather than guide you. So now in this case, the malaria parasite is negative and dengue NS1 is negative. So does it rule out malaria? Does it rule out dengue? So this is also very, very important to know. Now, as per the negative malaria does not rule out malaria. That is very important, because if you have examined the 100 oil immersion field on 3 consecutive days, and If the malaria parasite is absent by a skilled microscopist, then and then you can say that malaria is ruled out. So you need to resort to other method like the malaria antigen test. That is very, very important. So in the area, especially in the falciparum malaria or the mixed malaria, when the malaria parasite and RBC are sequestered in the vascular pool, the peripheral smear may be negative. If the malaria parasite density is low, I think the smear can also be negative. So these are the few situations probably where these tests are very important. So gold standard is microscopy, but you have to resort it. And negative smear does not rule out malaria. That is my first important message. So the malaria parasite can be negative. So it's a false negative malaria parasite can be there because if there is a too much reliance on the thin smear. So remember, friends, that we have to examine both thick smear and thin smear. Thick smear is 10 times more sensitive compared to thin smear. Thick smear is required mainly for the diagnosis. Thin smear is mainly required for the species identification. So most of the time we spend our time in preparing a wafer thinnest of the thin smear, but we forget the thick smear. So failure to make a thick smear will miss lot of malaria cases because the sensitivity of the thin smear is quite less. Similarly, I told that severe falciparum malaria, where they sequester the vascular pole, the peripherals will be absent. Prior use of antimicrobial malaria and unskilled microscopists, I think these are the cases where malaria parasite smear can be negative in presence of malaria. As far as the NS1 antigen is concerned, again, it is highly conserved dengue virus. Specificity is nearly 100%. So sensitivity for dengue fever in first 4 days is for primary dengue is 90%. For secondary dengue, it is 70%. As the antibody appears by day 4 or 5, the NS1 becomes negative. So it is very important when to ask for NS1. It is very, so the chances of getting positive is maximum on the day 2, day 3, and day 4. If the NS1 which remains positive by day 5, it indicates probably that we are going to deal with a severe dengue. Third one, that always, if possible, try to give all the three, NS1 as well as the dengue serology, because sometimes the NS1 is positive, but you may be dealing with a secondary dengue, and that's why it is very important to have all the three. So NS1 as an isolation is a wonderful test, you can do it, but when the child is sick, irrespective of the day of the dengue, you give all the three, NS1, dengue IgG as well as IgM. In a child who is otherwise playful, just comes with an undistant fever, you go for the NS1. But it's very important when to order and what to order. So there is no need that you go for the dengue serology on day 1 in all the cases. So on our case, on day 3, there was a fever which comes down by day 3, that is 90 to 100. But in spite of child becoming afebrile or less febrile, the child started having weakness, abdominal pain, vomiting, some puffiness face was there, and the child was ill looking. Now you can see that there is drop in the blood pressure as well. There is tachycardia is also there, and there is maculopapular and petechial rash is there. So this is a typical, very typical case, prototype case of the dengue. Clinically, we find out irrespective, even if the dengue here NS1 is negative, here we can confidently say yes, we are dealing with a case of dengue who has gone for the dengue with warning sign. So this is the chart. Now we do not use the dengue with shock or dengue with hemorrhage. Now we give that only dengue without warning sign, dengue with dengue warning sign, and severe dengue. And amongst the probable dengue with warning sign, it can be a live in the tribal to endemic area. There is nausea, vomiting, rash, body pains, positive tonic test, leukopenia, and any of the warning sign. So it is very important when the child comes to you, even if the child is walking, you need to explain the parents which are the warning signs. So fever is not the criteria. On the contrary, most of the complications will occur during peri-defervescence period. So once the temperature comes down, the hemoconcentration, leaking phase starts. So the child will have abdominal pain, tenderness. It is persistent vomiting, not a 1 or 2 vomiting, persistent vomiting, mucosal bleed, fluid accumulation. You may take the help of the USG also, lethargy, restlessness, there will be hepatomegaly, there is rise in the hematocrit and fall in the platelets. So these are the warning signs. It is very, out of this, the abdominal pain, persistent vomiting, and diminished urine output, and not feeling well, prostration, weakness. These are very cardinal signs as far as pediatric patient is concerned. So we usually ask the parents to look at the color of the urine in a crystal clear transparent bottle or a glass. And if if the parents say that this urine has now become darker, that means the urine has started concentrated. That means hemoconcentration is taking place, and this child has to be admitted and requires IV fluid. So it is very important that all these signs symptoms are there, but also look at the urine output as well as the urine color. Out of this, dark urine color is the first sign that we will encounter the child is going for oliguria. As far as severe dengue is concerned, it's a leaky phase. There may be hemorrhage, there may be organ impairment, and we can have a shock, we can have a fluid accumulation with respiratory distress. Severe bleeding can be there. AST and ALT can be high in thousands. There may be sometimes CNS involvement, sometimes involvement of other organs. So dengue is a one illness which can have a multi-organ involvement as well. But by and large, most of the time, dengue is a very disciplined illness. First 2 or 3 days is a prodromal phase, 3 to 5 days is a leaky phase, and 5 to 7 days is a phase of the recovery. So unless the complication like HLH or secondary infection take place, probably dengue is a very disciplined illness. Now in our case, we start with the IV fluid. You can see the hemoglobin concentration, which was 10, now it is 12.1. Platelets have gone down from 150,000 to 19,000, and dengue serology IgM turned out to be positive. So NS1 was negative, but here dengue serology was positive. So the limit of dengue serology is that in early infection, serology may be negative. So it gives a false sense of security. And by the time serology is positive, the diagnosis is fairly clinically evident. Either the child might have improved or the child might have worsened. So serology has very limited place. So what I want to emphasize here is that it is a diagnosis clinical, a thorough clinical examination, serial recording of the various vital parameters, urine output, and behavior of the child are very important. And along with that, a serial CBC and serial platelet will add to our diagnosis. So there is no need to go for the serology as far as the dengue is concerned. Now we also have got the various RT-PCR, which is now freely available. And if you are pushed to the wall, then you can also ask for it. As far as the monitoring is concerned, it is as well as most of the clinical. Again, I told you temperature. When the temperature falls, you have to be very careful, because most of the complication will take place in peridefervescence place. Child will have tachycardia. Always look at the blood pressure. At the same time, ask your resident to look at the pulse pressure. If the child becomes hypotensive, if the systolic pressure falls, it is too late. So we have to pick up when there is a narrow pulse, especially when it's less than 20. This is because the systolic pressure is maintained, diastolic pressure rises because of the peripheral vasoconstriction, and there is narrow pulse pressure. So it is very important to look at the narrow pulse pressure, cold extremity, then tender hepatomegaly, edema, mental status, CBC with hematogrid. The USC can help you. That is, it detects a plasma leakage even before the hematocrit rises. So I think USC is one of the most important tools. And I told you about you look at the urine output and develop a new sign like abdominal pain, vomiting, and serial CBC and serial clinical examination is all that is required as far as the monitoring is concerned. Now, if in spite of your IV fluids, your appropriate IV fluid, I will not discuss what is the amount, but if in spite of appropriate IV fluid, if the hematocrit is rising and the child is unwell, then the child needs more fluid. That is very important. But if the hematocrit is falling and the child is deteriorating, usually, if there is a good response with the IV fluid, the hematocrit starts falling. Urine output increases and child is looking well. But here there is paradoxical. Hematocrit is falling, but the child is deteriorating. So that indicates that there may be some concealed hemorrhage. And here it is most important to prevent the morbidity and mortality. And here probably you have to be very careful. Child might have internal bleeding and child may go into the shock immediately. So it is very important to find out the early detection of the shock. You have to be very careful. And for that, you need to know where the child is excessive sweating, whether there is restlessness, whether there is abdominal pain is or not, whether the level of consciousness has gone down, whether the extremities are cold or not, if the capillary refill time is more than 2, whether there is unexplained tachycardia, increase in the diastolic pressure giving rise to narrow pulse pressure, And most important, as far as CBC is concerned, up till now, we say leukopenia and thrombocytopenia. But in an otherwise unmarried child, if there is unexplained leukocytosis, it probably indicates, yes, this child may have got the internal hemorrhage. So unexplained leukocytosis is also very, very important as far as the early detection of shock is concerned. So as far as fluid, all the charts are available in various textbooks. But what is new is that you should never use isolate P. Always use normal saline. That is very, very important. You can use ringer lactate as well, but normal saline is should be the ideal fluid. And both as far as oral and IV is concerned, the ideal body weight or the actual body weight, whichever is lesser, should be used. So if the child is 50 kg, is overweight, then you have to actual body weight should be considered. That is very most important practical aspect. And if the child is more than 50 kg, you have to use treat as an adult. And during the entire critical phase, irrespective of the length of the critical phase, the fluid should be maintenance plus 5% body weight, that is 50 ml per kg, to maintain the perfusion of the vital organs. So day by day, now the entire concept is to reduce or to I would say to optimize the fluid therapy. That is very, very important. And you look at the urine output, which is 0.5 ml per kg per hour. So the higher urine output is also not required. So it includes the fluid given during exercise also, and the maximum weight for which the fluid is calculated. Any patient should not exceed 50 kg, and accordingly it comes to about 4.6 liters. So the cutoff for the adult dose is 50 kg, and you should give only maintenance plus 5% of the body weight. This is sufficient to maintain the vital organs. And you can see this is the used mainly in the Sri Lanka, and you can see the chart. You can see it is 1.5 ml, if not even 3 ml, 5 ml per kg, 7 ml, and then you can reduce to 5 ml, 3 ml, and 4 kg. So if it is there, these are the brackets for the adolescent and adult, where they do not give per kg per hour, but they give for 40, 50 ml per hour. So this is about the number of hours versus the fluid which is required. And it is very important that you have to maintain the urine output, and urine output should be 0.5 to 1 ml per kg per hour is sufficient to maintain the real renal function during the critical period. If the urine output is above 1 ml, probably it suggests that infusion rate is too high. So it is very important, clinical parameter and urine output is very, we always often concentrate mainly on the CBC, thrombocytopenia, but no, it is the clinical, and out of this, the urine output is one of the best indicator. Now, if in spite of this long exercise, if the child is not improving, probably you will look at the A, B, C, and S. That is acidosis, bleeding somewhere else. You can look at for the hypocalcemia and hypoglycemia as well. So again, these biochemical parameters are also very, very important, especially in an unwell child. So these are the various typical rash. I will not go in detail, but when there is you can see this white islets in the red sea. I think this is the sign where the child is recovering, and this is the child where all the skin lesions or the skin rash become more itchy, and this is the time that yes, the child is recovering. So dengue is a diffuse plague, purpura petechiae, and maculopapular rash. So there is a golden triangle: a meticulous monitoring, judicious fluid management during the critical phase, early detection and treatment of the concealed bleeding, and looking of the development of a new complication are very, very important for the success of the dengue shock. So this is another thing as about dengue. The another cousin of the dengue will be a chikungunya, where typically there is fever, rash, and arthropathy. And out of this, there is the rash are different as per the chikungunya is concerned compared to dengue. So there may be a morbidic fever rash, hyperpigmentation, especially in a young infant is there, ulcer in the groin. You can see this vesicular region is there, and it can also have a tan and generalized pruritus. So the pattern of the rash is quite different as far as chikungunya is concerned. Involvement of the joint is more common as far as chikungunya is concerned. Thrombocytopenia and hemoconcentration are less common compared to dengue. So this is a real case. These are you can see this. Once you see this, you never forget. So the classical rash of the chikungunya. And if you look at this, that in a dengue, thrombocytopenia thrombocytopenia, the bleeding disorder, and leukopenia is quite common, whereas the joint pain and muscle pain, that is, are more common as far as the this chikungunya is concerned. So that is about the chikungunya, dengue, and hand-foot-and-mouth disease. Now, another child who has got a fever, headache, myalgia of short duration. There are many cases in the community. Macropapillary rash 3 to 5 days after the onset. There is rash progressive to purpuric spot. Predominant of the extremity subsequently involve all over the body, including palm and sole. There is persistence of the fever for week, not weeks, week. There is edema and child progressive disease. So here you can see, compared to dengue is a very disciplined illness. It does not progress fast, but here the progress is fast. Not only the progress is fast, it has got the rash pattern changes very fast from macule to maculopapular to petechiae to purpuric, and can even have the gangrene. And on top, the child has got the edema and child worsens clinically. So this is very, very classical of the scrub typhus. So probably fever without focus, PO, fever with rash, fever with edema, fever with vasculopathy, fever with organopathy, fever with order. So in any form, this can present scrub typhus. Though it is described as a spotted fever, remember it can occur without rash as well. So spotted fever can be spotless. The important clue is that similar cases, typical epidemiology, rapid progression from one form to other form of the rash, and development of edema are very, very characteristic as well as the clinical diagnosis of scrub typhus is concerned. So a history of tick bite, recent travel to endemic area, similar illness family, long uncut grasses, animal states near houses, pet and stray. These are the epicenters where you can have a vector for the scrub typhus. This is a classical triad, fever, headache, and rash. You can see the eschar if it is present. I think it's a very, very pathognomic. You can see the involvement of the sole and rash, and you can see, yeah, and this is the eschar. And initial, it looks like a cigarette butt, and there is the involvement of the regional lymph node. So it's a painless necrotic. If it is there, probably it is the pathognomic, and here the immunochemical staining of the skin biopsy of eschar is very sensitive and specific as a scrub typhus. So most important to find out the scrub eschar, you have to first undress the child completely, and you have to look at the various specific areas. The eyes is what the mind knows. That is very, very important. So you have to find out which are the common sites where eschar is available and how is seen and how it looks like. And if you look at these are the common sites, you can see they are commonly found in the axilla. They are commonly found in the web of the nail. They come in the back. They can be there in the inguinal. So usually they are in the folded parts. It is very, very common. It is very often missed in a dark pigmented child as well. So it is very important to look at the eschar if this history is available. Now, there may be a severe cases where there may be a vasculitis, there may be a purpura, there may be gangrene. And so myalgia, restlessness, arthalgia, anorexia, vomiting, periorbital edema. So this is very, very characteristic. Edema, periorbital edema of the hand and feet, splenomegaly and hepatomegaly, third vascular space. So this is the one illness. After dengue, this is the one illness where there is third spacing. So capillary vasculopathy is also seen with rickettsia. So as far as all monsoon fever is concerned, if the child has got a third species, I will look at two different diagnoses. One is a dengue and second is a scrub typhus. And it can have any complication. It can have respiratory, it can see anything. Now, out of this, scrub typhus has now emerged as one of the commonest cause of the acute encephalitis syndrome in Asia and India. So nearly previously we said that yes, most of the time they are J. If it is sporadic, we have HSV. Now it's the time to rewrite our protocol, to write our textbook, and probably scrub typhus is responsible for nearly 30 to 35% cases of the acute encephalitis syndrome in an area where scrub typhus is known to occur. So it is very, very important that it is an important cause of acute encephalitis syndrome. So there will be initially the hemoglobin may be normal or low. There will be early leukopenia and low platelet count. But one of the consistent findings as far as the scrub type is concerned is hyponatremia and hypoalbuminemia. So with a typical clinical feature, typical epidemiology, if the child is hyponatremia, if the hypoalbuminemia is there, I think probably you are dealing with a scrub typhus. And now you are in this case, you start the doxy and you get the response within 48 hours, your diagnosis is made and there is no need to go over the microbial diagnosis for the confirmation. So as far as scrub, again, I will not go much in the debate, but these are the two common types. But out of this, The rest is only transient in scrub typhus, that is seen just in 40 to 60%. But in the case of Indian tick typhus, the rest is present in 90% of the cases. Though eschar is said to be pathognomic, is seen in scrub typhus in only 5 to 60% of cases. And as far as the Indian tick typhus is concerned, I think it is just a 3 to 5%. So there are various well-Felix tests, and well, I will not go into detail of it. But what I mean to say that absence of rash does not rule out scrub typhus. Absence of eschar does not rule out. If it is present eschar, it is pathognomic. So again, this is the various slides. I'm not good, but what is gold standard? Now, what is commonly used? Not gold standard. Gold standard is isolation. That is, you can go for the PCR or the isolated organism. But what is commonly available and are followed is the IgM capture ELISA. And there's a sensitivity of more than 90% and is highly specific. Whale Felix test is a good test, cheap, that easily available, but has got a poor reliability. And you have to match it with the clinical correlation and the epidemic background. So Whale Felix, though we do really do it, it lacks the specificity and the sensitivity. And what is more specific and more sensitive is a ELISA IgM PCR, usually not visible. And we usually in clinical practice we go for the IgM ELISA for the scrub typhus. As far as treatment is concerned, I think it's a doxy, and doxy. Even if the child is 3 months old or 5 years, irrespective of the age, you can start the doxy. Even if the child is less than 8 years, you have to give the doxy. That is the mantra. So do not hesitate. Do not think of the side effect, but just try to save the child with the help of the doxy. And you can know all the doses. Sulfonamide is contraindicated, especially in the child who has got a G6PD deficiency. Use of sulfonamide in a rickettsia often becomes a fatal one. So the only drug which is contraindicated in rickettsia will be a sulfonamide, and other drugs will be clarithromycin, fluoroquinolone, or rifampicin. They are so duration is 5 to 7 days, or at least 3 days after the deprivation has taken place. But in clinical practice, probably this fast response may not be there. So sometimes you may have to wait for it, but by and large, usually the response is usually there with doxy within 48 to 72 hours, and child improves within 7 to 10 days. Now, so these are the 3 important things. Now, in the post-COVID situation, the similar brother comes in our new our diagnostic armamentarium, that is a MIS-C. So it is often confusing whether we're dealing with dengue shock, whether we're dealing with rickettsia, and whether we are dealing with a MIS-C or no. So remember that COVID antibody positive plus similar picture is not equal to MIS-C. MIS-C is a diagnosis by exclusion. So you have to rule out dengue, you have to rule out cerebral malaria, you have to rule out septic shock. So it's a diagnosis by exclusion. If everything is ruled out, and if all the WHO criteria, 5 criteria is there, fever more than 3 days, a high fever more than 5 days, all elevated mucus, involvement more than 2 system, typical rash, non-executive conjunctivitis, plus evidence of the infection everybody, plus ruling out other condition, then you have to entertain the possibility of the MIS-C. So you have to remember that the vasculopathy can occur with dengue shock, with rickettsia, as well as with the MIS-C, but out of this, MIS-C is a diagnosis by exclusion. Another case, Monsoon 4-year child, fever with rigor 2 days, vomiting and occasional pain in abdomen. Child is otherwise alert, vitals are normal, liver is just palpable, spleen not palpable, and a child comes with this report that hemoglobin 9.8, TC little high, 14,000, platelet borderline, 1,55,000, PS per MP is negative, NS1 is negative, and NS is slightly. So here, I already told you that single NS and peripheral smear does not rule out malaria. Similarly, negative NS1 does not rule out dengue. But this child worsened, becomes now irritable after 24 hours, fever persisting, eating and drinking less, however maintaining vitals. And we again do the smear examination, and it turned out to be a falciparum ring form with parasitic of 6%. What I want to emphasize here that over a 24 hours, if the parasitic load is high, this child can deteriorate. So this is very, very important. And if this child comes in the midnight, if the laboratory is not available in a remote place, always keep a rapid malaria antigen test and kit, and that should be well preserved in the perfect temperature and in the perfect humidity environment. It is very, very important to have the efficient outcome as far as the RDTs are concerned. So RDT is a boon. If there is a 2 consecutive RDT are negative, the chances of not having malaria is more than 90%. So I think it is very important as to have RDT, especially those who are practicing rheumatoid or where the scale microscopy is not available. So when to suspect severe and complicated malaria? So it is very, very important that any child who has got a fever in the endemic area and at least one of the following, that is prostration, means the child is not able to sit or stand, unable to drink or vomiting, dark color urine or limited outcome, generalized convulsion which persists more than 2 episodes, severe anemia, altered consciousness, lethargy, coma, and breathing difficulty that may be because of the acidosis. So these are the any child who comes in the monsoon fever and any of these, your antenna should be up. Yes, it can be a severe complicated malaria. And out of all these, those 4 things which are marked with red, like impaired consciousness, acidosis, hypoglycemia, and severe anemia, they are very, very common as far as the pediatric severe malaria is concerned. They are less common in the adult. In adult, usually we have got the renal impairment, jaundice, pulmonary edema, shock, like all this. So I will not go into detail, but remember that severe anemia means hemoglobin less than 5, and it is usually normochromic, normocytic anemia. So it is remember that this is very, very important. Or if you look at the hematocrit, it is less than 15. Hypoglycemia means blood sugar less than 40. So these are the some definition that you must know about the various manifestation of the severe complicated malaria is concerned. Now, another $1 million question: can PYX be severe? Up till now, our traditional teaching is that yes, YX cannot be severe. No. Now the epidemiology has changed, the parasite has changed, the immune response has changed, and so they can have a severe anemia where hemoglobin can be less, thrombocytopenia, even massive splenomegaly leading to splenic rupture have been reported. They can have acute pulmonary edema, and ARDS is there. And another tricky is that in the case of falciparum malaria, the severity and the presentation and the organ involvement will depend upon the parasitic load. Whereas here, even with a low blood state parasitemia, these complications can occur. So this is very, very different as far as the vivax and the falciparum is concerned. So that is because falciparum malaria can involve mature, immature RBC all. So parasitic load is going to be high. Vivax involves only the mature RBC, and therefore, even with a low parasitic load, this complication can occur in PYX malaria. And you can see of the parasitosmia, again, a scale microscopy is required. If the more than 5% RBC are parasites, if the more than 5% polymorphs contain the malaria pigment, if more than 20% of the parasite contain visible pigment with mature trophozoite and schizoid, it's a severe malaria. In general, a child who has got trophozoite and schizoid are prone to more severe complication compared to a ring form. Why? Because these trophozoites and schizoid are the more mature form, and they are more prone for the rosetting, Rolex formation, and capillary blockage. As against the ring form, they are less cytoadherence, and therefore the chances of getting recovery without complication are more with the ring form compared to trophozoite and the schizoid forms. So as far as it is just like a tickling bomb. You have to be very fast. The outcome will depend directly on the time of the intervention. So hospitalization patient is very important, where the patient secure, collect blood sample and give the first dose of the parenteral anti-malarial. If the reference time is more than 6 hours, give at least 1 dose of the artesunate. Per rectal artesunate also available. Give at least intramuscular artemether. So give the first dose. That is very, very important. It will save the life of the patient. So always it is very important that it's a dire emergency. There are 3 only: meningococcemia, septic toxic shock syndrome, and the cerebral malaria are the 3 situations where the mortality directly depends upon the first dose of the antimicrobial agent. So mortality is usually within 24 hours, and significant correlation is there between the treatment and the starting of the first dose. So now some of the clinical situation is there. Suppose the child has a severe complex falciparum malaria, any complicated malaria, forget about vivax or falciparum, you have to treat it as a falciparum. Means if the child has vivax malaria and severe, again you have to give with the artesunate combination therapy. If the parenteral antimalarial has to be given for the first 24 hours for the rapid killing of the parasite. If you give the artesunate IV, that is rapid killing, 100 times more rapid killing of the parasite. So it is very, very important to bring down the parasite load. And once the child is okay, after 24 hours, you give the oral whatever is there. But as far as the severe malaria is concerned, the first 24 hours has to be parenteral and that too IV. If there is an uncomplicated PYX, you give chloroquine, but give the primaquine for 14 days for the radical cure. If there is a complicated PYX, I told you that you give ACT, but here you give the primaquine for 14 days. For the mixed malaria, that is P. falciparum vivax, again you will use the artificial combination therapy, but here the primaquine is required for the 14 days. There is no role of empirical anti-malarial drug. Howsoever the fever is there, but you do not show the malaria parasite. If you don't have RDT positive, please do not give the anti-malarial drug unless the child has got a suspected severe complicated malaria and alternative causes of the epidemic fever has been ruled out. So that is very, very important. And artemisinin is always in combination. And when the child has severe malaria, a serial blood sugar is a must. Child may be improving from the malaria point of view, but child may have a sudden episode of hypoglycemia and throws the conversion. And probably you may misinterpret, yes, the child, now the malaria has become now, simple malaria has now gone to a cerebral malaria. So no, always look at the ABC as well as maintain the euglycemia as well. Now these are the charge dose. Only thing that if the child is less than 20 kg, you need to give the 3 mg per kg. So previously we are using 2.4 mg per kg. If the child is less than 20 kg, you have to give for the 3 mg per kg. Now dose of primaquine is 0.25 milligram for Vivax and 0.75 milligram as a single dose for P-Palsam is concerned. For Vivax, we give it for the 2 weeks. So in our case, we treated with the artesunate and again managed with paracetamol. We give the resist, that is sulfapyrimethamine, but again he is back with the fever 1 month after the first episode. So here smear again shows the smear positive. So here remember that when the child has the come with the fever, or there is no response, do not use the malaria antigen test because the malaria antigen test will pick up the antigen. The antigenemia persists longer than the parasitemia. So you need to find out whether the asexual parasite is present or not. So here in there is a parasitemia was 32%. So it's a really a case of a treatment failure. So if the failure is within 14 days and there is recurrence of fever and parasitemia, I think you have to give the, maybe because of the monotherapy, incorrect dose, poor adherence, and that is the most of the time it is because of vomiting or intolerance or poor adherence. And in that case, it is unusual. But all these factors are taken, means the child is not vomited, dose is okay, compliance is good, adherence is good. In that case, you have to treat with the other artesunate combination therapy. But if the failure is after 14 days, then it may be a treatment failure or a reinfection, and here you can treat with the same antimalarial as. So message is that if there is a treatment failure which occurs within 14 days, first look at the tolerance and adherence. If that has been taken place, you have to change the ICT. That means instead of artesunate, you give artemether. Instead of ACT, you can switch over to quinine. Instead of second drug, the lumefantrine, you can give clindamycin. So or doxycycline if the child is more than 80. So these are different combination of permutations can be used. If the failure is after 14 days, again the same antimalarial should be used because it can be a reinfection as well. So that is all about the malaria. Now this is another a 5.5-year child, fever 5 days, vomiting off and on, drowsy, dehydration is there, pallor is there, and abdominal distance is there, and liver is 4 centimeters. This is the child. So he's got the fever as well as some GI manifestation, as well as the child has got the hepatomegaly, and child looks ill and dehydration because of the vomiting. And you can look at the blood culture is suggestive of this S type A. SGPT is very, very high. And we did the viral markers, and in that case, the anti-hepatitis A IgM is positive. So it's a combination, enteric fever as well as the hepatitis A. So remember, friend, that in a monsoon season, when the SGPT is always high, and even though you've got the one diagnosis like typhoid or dengue, always look at the viral markers as well. It can be there. So the co-infection with typhoid, and in spite of high SGPT, child was not icteric clinically. So a case of anicteric hepatitis as a hepatitis A. So as far as the labs is concerned, CBC is most important. Serology for vidalis we do not know. We don't ask for it. So there is no scope of typhoid dot. There is no scope of vidal. Just you give the blood culture, which is a gold standard as far as the diagnosis of the typhoid is concerned. Now, why? Because this rapid test, typhoid dot and spot and everything, they have got the more of the negative predictive value. then positive predict value. If the clinical features are suggestive of typhoid fever, you start the antibiotic after the blood culture and stop if the alternate diagnosis is made or continue if the culture is positive. Similarly, positive test, whatever type you do, IgM or whatever you do or rapid test you do, this positive needs to be correlated clinically and confirmed culture. So by and large, serology and all rapid serological tests for typhoid are not to be used in clinical practice. Rapid tests are only used during the outbreak situation where the pre-test positive probability is very, very high. So it is mainly used as screening during the outbreak. Otherwise, in clinical practice, we do not, it's a blood culture. If the clinical relation, you start antibiotic after blood culture and stop it if the alternate diagnosis is made. So these are the various doses. The drug is ceftriaxone. Azithromycin should be kept as a reserve, especially for the relapse. We should not use it because MDR typhoid is there in India, which is sensitive to ceftriaxone as well as cefixime. In Pakistan, we have got the XTR, wherein ceftriaxone is not working, and probably in that case, azithromycin will be very, very useful. Now, if you look at the Apex laboratory, here the ceftriaxone MIC keeps on rising. So, though the salmonella is sensitive, the MIC has gone up. So, in no time, probably we might have the resistance to ceftriaxone. In that case, we need to have azithromycin. If the child is admitted, you can ceftriaxone. If there is a severe drug sensitive with ceftriaxone, then in that case, you have used to azithromycin. So it is very important to find out what is the response once you start the ceftriaxone or the cefixime. So if there is an early response within 48 hours, most of the time it is not the typhoid, because the enteric typhoid bacilli are intracellular, and when you are using a third generation cephalosporin, the intracellular, they are not as efficient as azithromycin, and therefore the response will come little late. So if there is a response favorable within just 48 hours, you have to review the diagnosis. Why? Because the usual time for the clinical response is 5 to 6 days. Response means not only reduction in the fever, but child is taking orally well, becomes less toxic. So there is comprehensive improvement. If there is a delayed response by the end of the 1 week, but the child is doing well, only fever is there, and otherwise child is there, you have to reassess the patient. Do not start next antibiotic or do not add the antibiotic. And in 5% of the cases, there is really a therapeutic clinical failure, but in spite of correct dose, 5% of the cases, less beyond 1 week, continue to have fever. In that case, assess the child. Look out the various complications like splenic abscess or HLH or drug fever or thrombophlebitis. Other causes are ruled out. If everything is ruled out, then probably you will stop the cefixime, and here you start the other sensitive drug like azithromycin or even cotrimoxazole or the amoxicillin. So here you have to change the drug, but do not add the drug. So monotherapy is the rule. There is no role of the combination therapy as far as the enteric fever is concerned. Some patient in monsoon may come with fever as icterus. In that case, you find out viral hepatitis, malaria, typhoid, and leptospirosis. But very important that in case of hepatitis A, the enzymes will be in thousands, and fever will be mild to moderate. As against that, in malaria and dengue and typhoid, usually the fever is very high, often erratic, and the SGPT is usually hundreds. As far as lepto is concerned, it has got typical manifestation like bone pain, body ache, spinal pain, aseptic meningitis, red flush eye, which is non-exudative, and child may have the renal involvement, icterus, as well as the respiratory symptoms. So that is the child who has got the fever with icterus. So these are the cases that viral hepatitis, malaria hepatopathy, enteric, liver abscess, all these will have a high transaminase we have to clinically identify, and sometimes sonography may pick up the liver abscess. So friends, if there is a fever with or without chill, with anemia, with spleen, with or without thrombocytopenia, malaria is the first thing. If there is fever with retroorbital pain, rash, with muscle pain, with rising hemoglobin, falling platelet, it can be dengue, it can be myalgia and vasculopathy, and here rickettsia can be there. If there is fever which is more than 4 days, child becomes sick, liver spleen may or may not be there, thrombocytopenia may or may not be there, leukopenia may or may not be there, eosinopenia may or may not be there, rule out enteric fever. And if the child has got the fever, respiratory involvement, myalgia, multisystem involvement with thrombocytopenia, flu, lepto, and rickettsia, and the non-infectious condition can be there. So these are the various elements that we have to look into it to dissect the wide spectrum of the monsoon fever. So if it is a flu, there can be a notified outbreak. Predominantly is a respiratory illness, body ache, pneumonia, croup bronchiolitis, and microbial diagnosis will be helpful, especially in the case of indoor patient. If there is rickettsia, history of tick bite, typical epidemiology, fever, headache, malaria, rash, edema, hyponatremia, and hypoalbuminemia is there. Again, lepto, water clogging, heavy rain, chills, fever, conjunctival confusion, calf tenderness, spinal tenderness, and hepatic and renal. So these are the various syndrome that we can look into it and differentiate whether it's a flu, rickettsia, lepto, or not. So that so it is a syndromic approach. Any child who has got the monsoon fever, you have to stabilize the child, apply which clinical syndrome to fit it, fever with rash, fever with icterus, fever with respiratory syndrome, fever with CNS manifestation, or the child has got the multi-organ involvement. So that is very, very important. And accordingly, we have to look into it. So thank you for this wonderful opportunity. And if you have any question, I will be very happy to answer it. Thank you so much.
Thank you very much, sir. A very elaborative, very crispy lectures. It's really appreciable, and it was needed actually with the start of monsoon, just to update our knowledge. Sir, we have kept some 15-minute slot for question answers.
Yes, please go ahead.
And myself and Dr. Vikas More will be taking questions in chat box.
Yes, sir.
Because are there any questions in chat box?
Right now, sir, there are no questions in chat box because sir's presentation was self-explanatory.
Dr. Wankhede, if you permit. Hello, Dr. Wankhede.
Sir.
Yes,
If you permit, I would like to welcome Sudhir, Dr. Sudhir Kumar, our EB member and one of the best person I have ever seen in my EB. Of course, I work with Abhay Shah also. Welcome, Dr. Sudhir, on platform of Raigad IIP.
Yes, yes. Welcome, Sudhir, sir. Yeah.
Sir, please unmute. Please unmute.
Unmute.
Dr. Sudhir, you have to unmute it.
Yeah. I mean, it was a wonderful talk, although it was a little fast paced, but wonderful. You have covered everything. Thank you so much. You are a genius.
Thank you, sir.
So I have a question that if NS1 is not positive, then how to go ahead?
Yeah, so that is a very excellent, I think, question. See, most of the time we go for the NS1, and if it is positive, it is 100% specific.
Because please unmute.
Yeah. So if it is positive, 100% specific, but negative does not rule out. Why? Because if it is on a day 1, probably the antigen may not be there. If it is done on day 4 or 5, the antibody might have started developing, and this antibody has neutralized the antigen. So negative NS1 will not rule out. So in that case, what is more important is the epidemiology, what are the clinical features, and how the child is behaving. So I told you that dengue is a very disciplined illness. So by the day 3 or day 4, the thrombocytopenia, rash, some leaky phase will start. And so it's a serial CBC clinical examination is very, very important. And by day 4, you may get or 5, you may get IgM positive. And by day 7 or 10, you can IgG positive. But still, this serology may not be required. Only clinical outcome is very, clinical parameter is very, very important.
Thank you, sir. Thank you.
Yes, sir. Dabarga, sir.
Sir, thank you. It was very wonderful lecture. I had a lot of chances to listen you at so many places, and you are nationally acclaimed person for all these infectious diseases. Sir, just very simple question, clinical question. As far as bone pain is concerned, in dengue fever and in chikungunya, is there any difference bone pain? Because to the best of my knowledge, bone pain is there in both of the diseases, but to the best of my knowledge, it is very of short duration, rapid onset, and only smaller joints are to start with in chikungunya.
Yeah.
Not in. But I would like to hear your comments.
No, I totally agree with you. Smaller joints, fever, rash, and arthropathy. And predominantly the child will not come as a fever rash, but child say, I've got the fever and I've got the pain. And pain is especially mainly affected in the smaller joints. So I totally agree with you.
Sir, one more question for you. As
Yes,
you are
sir.
nationally acclaimed infectious disease specialist, and probably your words are more important. Your comments regarding combination of cefixime with ofloxacin.
Sir, I have never used it. Even never used. Number one. Now, why I'm telling you that previously we were using ampicillin, chloramphenicol, amoxicillin. But since last, I think in 85 to 90, we have got the multi-drug resistant typhoid, MDR typhoid. And these first-line drugs have now totally become resistant. So after that, we are using third generation cephalosporin, ofloxacin, and azithromycin. Now, out of this, if you look at the current scenario in Asia, not India, 98 to 99%, I would say 100% type Salmonella strains are resistant to ofloxacin. So there is no point in giving cefixime. You are just giving a placebo. On the contrary, you are transmitting the plasmid mediated this resistance genes. So only give cefixime. If the cefixime is working, it may take 4 or 5 or 6 or 7 days. At times I have seen even 8 or 10 days. But the child is doing well. Do not just look at the temperature chart. If the child is doing well, temperature spikes are coming down. The duration between the two spike is getting longer, and the child is taking orally well. It is a response. It is not that if the fever is 98.4, then and then it is a response. No, it is not that. We have to comprehensively see the child. And if the child is well, you continue cefixime, reassure the parents. But as rightly said, that if it is 7 or 8 days gone, in spite of a good correct dose of cefixime as per the culture report, if there is no response, it's a clinical therapeutic failure. In that case, you look at the sensitivity report and choose the sensitive drug. It may be azithromycin, it may be cotrimazole, or even it may be a amoxicillin. So I think that is so never add to drug, just change the drug, and that is required only in less than 5% of cases, very, very rarely.
Can I say something, Dr.
Yes,
Wankhede,
sir. Yes, sir.
Dr. Abhay sir, as always, we learn to listen to you always, and it's always a pleasure to listen to you, and always we gain new knowledge. The point what Davarkar sir said, and I feel so, when it is such that ofloxacin is one of the drug which can be used in as a second line drug for tuberculosis also, but then why it is flooded in the market? Because if we listen to a lecture, we follow your advice, we will not definitely will not use. But the use of it is so much in the general practice level or other levels, it is so much flourishing in that, and it is promoted like that. So that is the way. Is there any way of our IAP can
IAP leadership and even the ICMR, they are breaking their heads. They are breaking their heads, but the general people, the quacks, the paramedics don't understand the importance of it. Remember the days that probably a child with tonsillitis need ICU, need an ICU admission after 10 days down the line. So if this is going to continue, I think I agree with you. We need to buck up now. It is very important. We have got so many modules: war, avoid antibiotic, rational therapy. But still, I think the awareness is only amongst the pediatricians. But for other fraternity, with the due regards, this type of awareness is not there. I totally agree with you.
The point was that whether we on behalf of IAP, we can just make the FDC, the whatever the drug approval is there, that should be banned. Means it should not come in the market itself.
Yeah, I totally agree with you. I think there must be a political will for that. I totally agree with you. And IAP can play a leading role in that.
Sir, I would like to ask you one question. When patient comes to us at the day 7, day 8, he already he has taken ceftriaxone on the day 3, day 4 with haphazard doses. And if we go for blood culture, we may not get, even if he's positive, we may not get a positive culture. Yeah. So in that case, how to tackle, how to go?
So there are two important things. No investigation is going to be helpful unless it is supported by clinical parameters. So child who is fever which is more than 5 days, toxic child, not eating well, there is no focus, you have ruled out other like tonsillitis, UTI, then what illness remains is a fever, probably bacteremic illness without localization. And commonest bacterial illness in India without localization is typhoid fever. And second is the occult bacteremia. Now, here the blood culture is very important. But as you mentioned that probably the child has been exposed to antibiotics, the chances of getting blood culture are less. And even if it is an antibiotic naive, the culture may be negative in 20% cases. But fortunately, Salmonella is the organism which are easiest to grow, number one. Second, now we have got the various culture which contains resin, and it has got which will nullify the action of the antibiotic to some extent. Number two. Number three, if you start the blood, you collect the blood in a route amount in a proportion of 1:5, growth and the culture, blood and growth. I think that is very, very important. Not less, not more. Even if you take a more blood, I think there are a number of bacteria inhibitors are there which will inhibit the growth of bacteria. So appropriate optimum blood culture growth ratio, blood growth ratio is very, very important. And if you take all this care, still because of an antibiotic, the culture is going to be negative. In that case, what is required is a clinical. And for that, suppose you have started the ceftriaxone in a correct dose. And if you get the response within 24 to 48 hours, it is not a typhoid. It is not a typhoid. So it is not typhoid, right? So if the response start by 4 or 5, it matches with my clinical impression, I will continue with the antiretroviral, and simultaneously, I will look at the other alternative diagnosis.
Sir, just a minute. In that case, if we go for rising Vidal,
yeah, it has some value. Yes,
yeah.
If you know the baseline titer, if you know the baseline titer, the rising titer will be helpful. I think we don't do it because to give the common message. Once in a while, you can ask for the Vidal test, but big no to typhoid. It has lot of variables. It has nothing type of negative positive predictive value, nothing.
Hello.
Sorry, Vikas. Yeah.
Yes, sir. You can go ahead,
sir. Yeah. Good evening, sir. Sir,
I'm
from Alibag, and there are a few pockets in the periphery of Alibag from where we get typhus patient, Indian tick typhus patients.
Yeah.
And I heard from your lecture that however young the child may be, how small the child may be, we have to use doxycycline as the drug of choice, first drug of choice.
Yeah.
Often it comes in capsule forms. It is very difficult to administer to younger child. And do we have a second line drug which can be used as first line drug?
Yeah, we can have chloramphenicol, we can have the clarithromycin, and we can have even quinolones. But I think WHO recommends, irrespective of the age, you give the doxy. You can open up the capsule. If injectable doxy is available, you can use it.
Okay.
Tablet formulation is there of doxy, Rajendra.
Brand name. Okay. What?
Easily.
Okay. Brand name.
Okay.
Okay.
Brand name by SK Docs. SK Docs. It is
SK Docs. Okay.
Yes.
Okay, sir. Yes.
And Doxol is one of them. Doxol Karimonu. Doxol.
Doxy also available.
Chat box में प्रश्न है. What is the blanket treatment? Blanket treatment of febrile encephalopathy.
Yeah. So it is also a very practical question because child who has got the encephalopathy. You remember that there are two important parts as well as CNS. Child who has got meningitis, that is meningoencephalitis. And another child who has got the encephalomeningitis, means the encephalitic component is predominant. What we describe as a febrile encephalopathy, or it comes in the definition of acute syndrome. So whenever the lumbar puncture is the most important thing, and if you ruled out the pyogenic meningitis, but before the report comes, I think you have to give the blanket treatment. So you will, to cover this meningitis, bacterial meningitis, you will give a ceftriaxone. Commonest cause of the acute encephalitis syndrome, sporadic one, is a herpes simplex. So you give acyclovir. If you are living in an area where the scrub type is known to occur, you will start the doxycycline. And if the child has got respiratory symptom or X-ray is positive, you can add atypical organism coverage with the help of azithromycin. So I think I agree with that. It is a blanket coverage. But once the alternative diagnosis is made, suppose you find the cerebral malaria, you may have started artist, you continue artist, remove the rest of the things should be stopped. So if the alternate diagnosis is made, you narrow down to a specific treatment. If not, then you continue the blanket treatment.
Thank you, sir.
So there is one more question. Why can't we use azithromycin as a first line if we are suspecting enteric?
Yeah, because so azithromycin is an excellent drug for any intracellular organism like Salmonella. Even for the Shigella, we can use the azithromycin because it works like that. But remember that this azithromycin is mainly for the atypical organism. Now some of the clarithromycin has now been used for even MDR TB. So there will be a cross resistance. And number 3, The most important, the first line is that we are now on the verge of the XDR typhoid. XDR typhoid is looming on the horizon because though we have got the sensitive salmonella to ceftriaxone, probably the MIC keeps on rising, and therefore we need to salvage this drug. Otherwise, for XDR typhoid, there won't be anything. We have directly jumped to meropenem or azithromycin. So it is very important to salvage azithromycin for atypical organism, for MDR TB, as well as for XDR salmonella.
So there is one more question, that is Salmonella paratyphi is an emerging bacteria in the India with increasing typhoid vaccination?
Yeah.
If so, does it respond to antibiotic?
Yeah, the study from the Pakistan showed that nearly out of 5, 1 case of enteric will be paratyphoid. And among them, paratyphoid is very common. So I think we now, trials are going on, and there is a comprehensive vaccine coverage for typhoid VI as well as for the paratyphoid A and paratyphoid B. So I totally agree that paratyphoid is on rise, and we need to prevent it with the help of the conjugate vaccine. Yes, Palani sir, boliye.
Yes, sir. It's a wonderful and exhaustive, fantastic revision, sir. And thank you very much.
Thank you so much.
And one small message I want to give all the practitioners are thing, particularly when you have a fever of 4 to 5 days duration or 5 to 6 days duration, along with the clinical course, how the fever started, how it is progressing. And when you look at the CBC, all the tropical fevers or all the monsoon maladies which Sir has talked today will produce leukopenia except for leptospirosis. All the things when you look upon, it will produce the counts less than 5,000 mostly, because typhoid may not, but mostly all the tropical fevers and monsoon maladies, see to that they will produce leukopenia. And with raised CRP, except dengue. Dengue will not produce raised CRP. So it is a leukopenia with raised CRP, all the tropical fevers except dengue. Leukopenia with normal CRP, mostly dengue.
And second, SGOT will be very high as per lepto compared to SGPT and lepto. Of course, it is high, dengue, malaria, everybody, because it's a non-hypertrophic illness. But in lepto, it is distinctly high. SGOT is quite high compared to SGPT.
These are a few small things. Yeah.
Thank you, sir.
Yes, sir. Davarkar, sir.
Sir, thank you very much. You have drawn your, you emphasized on azithromycin. I would like to draw attention of all pediatricians, especially family physicians. They are using azithromycin like anything. So azithromycin is the drug. This should be emphasized all the time, that azithromycin is the drug which should be reserved for drug-resistant typhoid and drug-resistant tuberculosis. Remember that suppose a resistance develops to ceftriaxone, then we don't have any other drug except azithromycin. And azithromycin should not be used like water, which all general practitioners are using because of its beauty single dose and 3 days course. So probably azithromycin should be reserved.
To emphasize what the sir is that odd fever is not a ceftriaxone deficient syndrome. All RTI are not azithromycin deficient syndrome.
Sir, not general practitioners, even pediatrician we are using lot. Huh?
I know it. I know it.
We should
but
stop
still,
first.
Still we are better placed. Still we are better placed compared to other fraternity.
Yeah.
So you haven't commented anything regarding ceftriaxone deficiency syndrome. That is the most important disease which we are facing nowadays.
Yeah.
Thank you very much. It is wonderful. Wonderful.
Sir, can you share something regarding RSV pneumonias in monsoon?
Yes, I saw this. See, it's the respiratory illnesses are very common, and they also can keep because of the time I did not touch the respiratory part, because when the child has got respiratory symptom, it can be a simple common cold, it can be a flu, it can be a undifferentiated any viral illness which subside often, and it can be have a lower RTI. Amongst them, viral are more common than bacterial. So we keep on talking of bacterial most of the webinar. I think viral pneumonias are the more common, and amongst them RSV and human metapneumovirus. These are two emerging ones, and third one is the influenza B. These three are coming up like anything in the recent time, especially in the post-COVID. But I think the Dr. Sriram has said that you can give the ribavirin, but we have never used ribavirin. And it's most of the time the RSV pneumonia or any viral pneumonia are self-limiting. So ribavirin is not specific anti-RSV. Once in a while we get the report, the response, it may be either natural cause of the disease, or sometimes the ribavirin might have worked. But as far as the literature is concerned, there is no recommendation of the ribavirin as far as RSV pneumonia is concerned. But I agree with him that RSV pneumonia is high, and with the availability of PCR multiplex, we pick up more and more this influenza, more and more adeno, and more on RSV.
So the important question is, sir, how do you differentiate viral pneumonia from bacterial pneumonia?
Yeah, so it is again very common. So anything that sneeze and wheeze is viral. Anything that sneeze and wheeze is viral. And there is multiple involvement. There is upper respiratory infection, lower respiratory infection. Child might have a few loose motion and similar illness in the family. There will be a bilateral involvement. There was scattered rals, there is wheezing and scattered crackles. Bacterial is a localized illness where only some bronchial breathing, some crackles, a local site is there. And there is no sneezing. There is no even more than one mucous membrane. And the tachypnea will be more. Sometimes X-ray may not be that bad, but the child with a viral will have more prone to hypoxia because of the involvement of interstitial tissue. So these are the features that will help you. And on X-ray, you will have cotton wool exudated air bronchium bacterial. This is very, very absent as far as the viral is concerned.
And bacterial will be more toxic, sir.
Yeah, yeah, yes.
Something regarding acute gastroenteritis due to various reasons during monsoon.
Yeah, so yeah, so again, this is a common illness day to day. So as far as the gastroenteritis is concerned, most of the time, those gastroenteritis which are causing acute diarrheal disorder with dehydration, they're mainly of the viral. Even if the child has got 104 fever, if you look at the stool exam, there are 50 to 100 per cell in the stool. If there is a leukocytosis count 20,000, CRP more than 40, still it is a viral. So do not misguide yourself because the count is high, because the child has high good fever, because the pus is there in the stool. You start the antibiotics. I think this investigation will misguide you. There is no need to do CBC. There is no need to CRP. There is no need to go for the stool as a routine acute gastroenteritis with dehydration. Just give IV fluid, ORS and zinc and paracetamol. Our child will be all right within 48 hours. If it's not improving, you go for this. Otherwise, not good. Only exception is immunocompromised child and severe acute malnutrition. These are two things. Otherwise, there is no need to. And if you look at visible blood, gross blood in the stool, then you start the antibiotic. That is bacillary dysentery. And here the drug of choice is cefixime. And they are here only give only 8 milligram per kg, only for 3 or 4 days, not 7 or 8 days. So here there also there is a role of the antibiotic stewardship.
So one more practical promotion coming in the market is regarding the respiratory probiotic. So how much it is relevant?
No, not at all. No, I think I have not used it, but this all are the
gimmicks,
pharma gimmicks, and they are very tempting statements from them, and we often land up in giving one or the other drug as a placebo. We also know that it is not working, but still, patient comes today, then comes after 2 days, the same company, we add something. And to add something, we use the probiotic. But I have never used it, to be very frank.
So something regarding tomato fever and monkeypox.
Monkeypox, yeah. So now the only typical picture is that the rashes are very confluent. They have got a wide erythematous rash. And they are very confluent. And there is a history of traveling to the endemic area and similar illness in the family. And they deteriorate very fast. They are very fast. That is the one.
And tomato fever is nothing but HFM.
Yeah, it's nothing. Tomato fever is nothing like that. Yeah, I agree with that. Nothing like
that. Wankhede sir, like we are coming to the end of the session.
Yes.
Wankhede sir, I would like to say something.
Yes, sir.
Sir, I don't remember exactly when I heard you, one of the module, when you said the use of antibiotics, whenever one audits ourselves, it should be less than 14 or 13%.
13%. It's a war module. It's a war module.
And that statement really impressed me a lot. And I always feel that one should start from ourselves only, because always I feel preaching is easier than practicing. And then since then, really to say, I'm not glorifying myself, but I really stopped clavulanic acid molecule.
Exactly.
I'm not using it totally, unless and until it is indicated, only then tablet form, because syrup form is unstable form and it really requires proper giving. So I really stopped. And almost, I think so, it on that module almost 1.5 years back, I think so.
Yeah, exactly.
And
Now,
so
and now,
so I'm
to,
using,
to reinforce your statement, I urge everybody to ask your staff at the counter in how many number you have started antibiotics. Suppose you see a 50 patient,
yes,
and see what is the, so this will improve by yourself. On the very next day, your pen will hesitate. No, rehne do, kal bulayenge. So I think it's a good exercise. So it should not exceed more than 13%, 1-3, if you want to be an antibiotic steward.
So I stopped that and use amoxicillin only, and other antibiotics really started using rationally. So I think so, because one important message is there. If we as pediatrician write rationally, that is a prescription followed by the general practitioners.
Exactly.
We should not blame the general practitioner. General practitioner follow the prescription of the pediatrician. If we make rational write our prescription, probably that will be followed in the general practitioner, and that will decrease the everything, the prescription.
Exactly. Preaching, teaching, and practicing all should be in the same line. I totally agree with you.
Thank you, sir. Thank you, sir.
Thank you that you remember my word, our IAP modules word, rather, not mine.
Now, sir, Wankhede, should we conclude the session?
Yes, sir. If there is no questions in chat box, or if nobody is asking questions right now, so we should conclude.
Now, I request our dear Dynamic Secretary, Dr. Dhananjay Rajput, to give a Thanksgiving note.
Thank you, sir. We are really fortunate today to have Dr. Abhay Shah, sir, as a speaker, a true academician, a stalwart in the field of infectious diseases, and a very humble person. It was really generous on his part, as he immediately accepted our request to be present on IIP Raigad platform. On behalf of IIP Raigad, I heartily thank Dr. Abhay Shah, sir, who spoke extensively on a very apt topic, that is Monsoon Maladies, which will be really helpful for all of us in treating our patients during this monsoon season. Once again, I thank you, sir. I sincerely thank Dr. Pramod Wankhede, sir, IIP Raigad President, for wonderfully moderating the session. And it was his idea to have Dr. Abhay Shah, sir, as a speaker on this very important topic. I sincerely thank Dr. Hemant Gangulia, sir, MAHA-IIP President, Dr. Shekhar Dabhadkar, sir, Dr. Palni Raman, sir, Dr. Sampath Sasane, sir, Dr. Vikas More, sir, Vice President, IIP Raigad, for their valuable inputs during this session. Finally, I sincerely thank all the delegates, all the seniors who have attended this session. And sincere thanks to Dr. Vishal, sir, for making the Zoom platform available for this wonderful session. Thank you, one and all. Thank you very much.
Sir, we wish to see you as elect in 2023.
Thank you, sir. Thank you, sir.
सर आपको एक बार फिजिकल आना है क्या एक मॉड्यूल को?
हाँ सर, फिजिकल आना है सर.
जब भी बोलो, sure.
Mostly the session on vaccinology and immunology.
Sure.